Good morning, everyone. Why don't we go ahead and get started today? Thanks, everyone that attended, that is here today. Hope you hope you all missed me last month. Unfortunately, I had a. Jeez, can you feel the love? Unfortunately, I had a little medical emergency with our 6-year-old, and it's been actually a pretty stressful month. But yeah, I got to make it back here.
How did it turn out?
She's medically out of the woods, but she has some lingering behavioral effects from meningitis and encephalitis. So it's going to be a pretty tough road for a while. So, but anyways, thanks for coming today, and special thank you to the Sanford Burnham Prebys Medical Discovery Institute for giving us this auditorium to meet in. Our IPCSG principals are Bill Lewis over here at the door, our president, who also does the newsletter summaries, Jean Van Vliet up here, our director and treasurer, Steve Pendergast, our secretary and newsletter editor, Bill Manning, director and videographer, myself, Aaron Lamb, and John Tassi, our webmaster. And of course, there's you, well over 900 members. Everyone is a volunteer, and you can be too. How many newcomers do we have today? Wow, quite a few. Excellent. Did all of you get a newcomer packet as you came in?
No, I forgot to bring them. My wife is bringing them. We'll hand them out.
Okay. That's all right. So we will, please, before you leave, get one of these newcomer packets and fill out and return the cover sheet. You can bring it back to me here at the podium or to Bill or Jean. These have some information kit with articles and booklets, and one of these guys will give you a call in the next week or two to discuss your own personal situation and see how the group can help. So how about an all hands welcome? Please raise your hand. Again, here if you were here for the first time. I want to take a count. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. Excellent. Excellent. And how many people have been recently diagnosed? Raise your hands. Well, I guess recent and is, last 6 months haven't started any, haven't made a decision yet on what to do in terms of their treatment and so forth. All right, excellent. And how many people have had prostate cancer for less than 1 year? Got their diagnosis less than a year ago. So still plenty of recent people. How about 1 to 4 years? All right. 5 to 10 years. I actually just passed my 5-year mark. And 11 to 15 years. And longer than that.
20.
So for you, yeah. So for
Can I say something about 20?
Sure.
I had my first treatment in 2003, January 2003, but I was diagnosed in September. Fortunately, a few months later, or 3 years later, I heard about the prostate cancer support group, and just like the newbies that are in here now, I was given information that helped me get in control of the situation, and they sent me to see this man who has been dealing with me for 16 years.
Oh, excellent. So the takeaway for those here for the first time is that prostate cancer, while it can be a scary moment in your life, it is a moment along the path of your life. You certainly have a long life ahead of you. So as you saw in the I didn't even realize the slides weren't advancing here. Sorry about that. Let's try this again. Yeah. There we go. Okay. Yeah, as you saw on the first slide, prostate cancer is 2 words, not a sentence. So in terms of a treatment summary, who here is on active surveillance? If you'll raise your hand. All right, several of you. And surgery? How many have had surgery?
All of them.
Yeah. Who has had radiation, whether proton, X-ray? Very popular treatment. How many people have been on ADT and hormone therapy? Yeah, quite a few of us. Chemotherapy? Yeah, still quite a few. More than when I first started coming here 5 years ago. New treatments, such as focal treatments, HIFU, laser, cryo, immunotherapy, Prevenge, Xofigo, Pluvicto. A lot of very new, exciting treatments that are out here. How many people have had recurrence, where they've had treatment, prostate cancer has gone away, and then they've had a recurrence a little bit later on? And who is undecided on future treatment? And that's probably why a lot of people are here today, to think about the future and figure out what to do next. And so, again, for you newcomers, those people that raised their hands, they've been through this in various forms and are a valuable asset to ask questions to. And feel free, especially after the meeting, to ask, go up to other people, come up to us up here, ask us any questions that you might have. Because, as I said, we're all volunteers. We're all helping each other here. How many people have sought out mental therapy? This is not something that a lot of people have considered, but it was, especially for me, extremely important. I was single at the time of my diagnosis, and really my therapist was my partner getting through all of this. How many people are on antidepressants? I am myself, and again, it's especially with the hormone therapy and your energy levels dropping and so forth, and the lack of testosterone, antidepressants can be extremely helpful in getting through those times. How about have had procedures to address incontinence? Nobody here today. And how about sexual wellness treatment, such as gone to see Dr. Shea, who's come to speak to us sometimes? Also a very important aspect of treatment, something that is probably all in the back of our minds, even if we don't want to admit it. But I have certainly gone through a fair amount of treatment myself and have some experience. Feel free to come up and ask me any questions that you want to. How did you get here? How many people were at the UCSD Patient Summit in January? Yeah, and how many of you were newcomers that saw us, saw Bill and I there, and that's what brought you in here that time? What's that?
We were handing out brochures.
Yeah, we were handing out the brochures. All right, I guess we got them all in the last couple of months. How many were referred by word of mouth from another patient? All right, excellent. And referred by one of their medical professionals. All right. Anyone new that was referred by a medical professional that they could share their name? Yeah. Yes, Dr. Rose is great. Siebert, yeah, also a good one. We've had other patients of his in here as well. How many found us by Google search? All right. I think I did too. How many people have seen the bumper stickers or the trifold brochures? All right, yeah. And how many of you had a spouse that discovered us and dragged you in? Yes, excellent. Yes, I mean, our spouses are one of our biggest assets in all of this. At times we might not want to deal with situations, but it's our support group around us that help us in addressing some of those issues. Now, any other places that I have not mentioned that people heard about us? Nothing. Okay. All right. And sorry, to go back to the newcomers here, if you could raise your hands. How did you? Did anyone? Sorry. How was it that you guys heard about us again? A friend. John Tassie. Okay. Yep. Friend. Okay. Friend. And these are friends that are already in the support group. Excellent. All right. It's great to get the word out. And thanks to Bill, we are now on Instagram. That's an accomplishment in of itself, I'd say. Yeah. This is the Instagram name, address. I'm not on Instagram, believe it or not. So I don't know too much about it, but please do. Find us on Instagram. Bill's been putting up posts every day. Please follow us. Click on some of the posts. Like them. That will add more credibility to our organization. As of the other day, Bill told me that we have 80 followers, and I would love to hear that we are trending on Instagram. That is the latest thing.
It's only been 2 weeks.
Yeah, Yeah, excellent, excellent. Now, our support to you comes in the way of our website that hopefully all of you have seen. Fantastic information there, links to a lot of information, past meetings, announcements of upcoming meetings, everything. We have a YouTube channel with a lot of our old meetings, meeting recordings there. You also should be getting the newsletter either by email or by special request by mail. You can also get those off of the website. Again, a huge amount of information, especially the latest and greatest medical articles on there. And of course, there's the monthly meeting every third Saturday of the month, but not in December. And also, these numbers are on the website. We do have hotline numbers that you can call. I know that when I first got diagnosed, I was really scared, just wanted to talk to someone, and these hotline numbers are for people such as that, like might be saying, what do I do? You know, like I have a doctor pressuring me to do some particular treatment and do it this week. Is this a good idea? You know, that is a perfect kind of question. And especially the last number here, Sharon has offered to be hotline support especially for women, family, and caregivers that can be, you know, stressed about this type of situation as much as the patient themselves. And we do ask for volunteers. We need people to suggest and recruit new speakers, as well as share your experience. So again, contact us if you have ideas there. And I'd like to remind everybody of our support group purpose. So we share patient-focused experience on becoming your own case manager through informing, networking, and caring. We are a group of experienced participants, but we are not medical professionals, and any sharing by anyone of our group may not substitute for your own medical counsel. And we do need your support. We are a 501c3 nonprofit organization. The donations are tax deductible. There are no medical or religious affiliations, and our largest costs are the website, advertising, mailings, etc. So please do consider making a donation to us. We provide support to other, we give donations to other research organizations that we are fond of that provide us a lot of useful information and so forth. You know, I just can't stress enough how important your contributions are. You can also make online contributions via PayPal at our website or by sending a check to the address that you see. Again, address is also available on the website. Next month, our upcoming meeting will have the Provenge group as well as Sparrow Research coming to give us some details on their work. But for today, we have, once again, Dr. Richard Lamb, Research Director of Prostate Oncology Specialists. He's going to give us some updates on the latest trials, testing, and treatment for prostate cancer. Dr. Lamb has been a fantastic resource for you know, a ton of people in this room and throughout the organization over many years, as Jean has said, and we're really lucky to get him to come every year to speak to us. And so let's, I guess you want to take questions, you know?
Today's going to be very interactive.
Okay. All right. So, you know, go ahead and feel free to ask questions. I'll run around in the audience with the microphone so that we can get the question on the recording easily. And so with that, Dr. Lamb, please take it away. And you've got So laser pointer if you want it, and then this middle one advances the slides.
Perfect, great, thank you. Good morning. It's so good to see so many people now. It's the pandemic is hopefully in the rearview mirror, and we're moving forward with life. And I think the last time I gave a little talk, it was via video. It was like Zoom call, and there were maybe 20 people involved, and we had a fun time talking about genetics. Today's going to be a little different approach today. Because as Aaron was polling everyone, there's all kinds of patients here, or men and women here, going through different facets of the prostate cancer journey. So hopefully we'll touch a little bit upon everything so that every participant here will feel like they learned a little bit that applies to themselves. So the topic, the title today is basically the medical journeys of a prostate cancer patient. Okay, so when, you know, it could be a 20, 30-year journey, but the first step in this process is that darn PSA. So typically nowadays, when a patient finds out he has prostate cancer, it's via a PSA blood test by their doctor. The other spectrum of diagnosis is when someone has some symptoms, and then that leads to a diagnosis of prostate cancer. So we'll talk about that a little bit later. But the initiation process into this world of prostate cancer is typically done by a primary care physician, a nurse practitioner, who just throws in a PSA test during the visit. And sometimes the patients don't know they're being tested. And then the next thing you know, the doctors say, come back in, your PSA is elevated. So then you got to make a diagnosis, and then you have to face, the whole process. So the second part of the process is picking a treatment. So how do we get rid of this mothership, this thing that's causing us mental and physical, more likely mental anxiety? And some patients, don't even need treatment. So this is where something like active surveillance comes in. And then the next part of the journey is to talk about or consider or suffer from side effects. And that is such a big part of the interaction of a patient and his doctor. It's not necessarily treatment, but just managing one's quality of life. And that alone could be a 20-year process of the patient evolving. So you get treated, you're managing your side effects, you survive. Darn, the cancer's back. And usually, how's that coming back? Well, that PSA again. Okay. So how do we deal with relapse? And the relapse process it's very complicated. It could be you've relapsed and you only have a couple of years to live, or you've relapsed and, well, you're probably going to die of something else. So, let's manage it accordingly and not be too aggressive. So every patient who relapses doesn't necessarily have to have more treatment. So that's where we talk about treatment options or active surveillance. So let's say you're unlucky and at later part of this journey you have advanced disease. So advanced disease used to be a death sentence, 20 years ago, and it was chemo, and then goodbye. But thanks to advances in medical research, there's a lot of treatment options now that will prolong life dramatically, and so we'll touch upon that a little bit as well. So let's rehash what Aaron was asking. Again, how many people are just in the beginning phases where they just got diagnosed or they have an elevated PSA? Okay, so a handful. So we'll try to elucidate some factors, and this is a time to ask questions too. We're going to make this fairly interactive rather than me throw out a bunch of slides and then you guys ask questions later. Okay, so elevated PSA and making the diagnosis. First thing is your PSA goes up and your doctor says, go see a urologist. Or sometimes, if you're lucky, the doctor will say, let's check another PSA, make sure it's not a lab error. Or let's make sure that you don't have a prostate infection. Or maybe you just had sex that morning and your PSA went up because of that. So that's under the category of other diagnoses. So when you have an elevated PSA, it's not always prostate cancer. So the factors, and I'll jump to the other diagnoses first, is when you have a high PSA, oftentimes if your PSA is rising slowly over a period of 10 years, and your doctor just noticed the PSA is high, then sometimes it's not even prostate cancer. It's just the prostate gradually growing, okay? So that's a factor, that's a diagnosis called benign prostate hypertrophy. So with regards to the PSA behavior and benign prostate hypertrophy, when your PSA is rising gradually over many years, your prostate is growing gradually over many years. So an elevated PSA oftentimes is simply related to a big prostate. So there's a little formula called PSA density that it's important to know. It's basically the PSA number divided by the size of the prostate. So if your PSA is 10, which sounds high, but your prostate is very big at 100 grams, so 10 divided by 100 is 0.1, okay, right? So it turns out that if your number is 0.15 or below, then it's either you probably don't have prostate cancer. In other words, your high PSA could be explained by your prostate enlargement, or if you have prostate cancer, it's not the serious type. Of course, exceptions arise. So let's say you have a giant prostate, but your PSA was 1 in 2022, and then it jumped up to 10 in 2023. So that's a very dramatic rise as opposed to going up from 9 to 10 over 1 year. So that's where if the velocity is fast, even if you have a big prostate, you don't want to just say, oh, it's just a big prostate, don't worry about it. You got to remember the PSA went up very quickly, so there could be something serious going on. Yes?
Quick question. How do you determine an accurate?
Great question, which we'll talk about at imaging the prostate. Okay. So with kinetics, PSA going up fast or slow. That's basically the thing to know about when the doctors are faced with a patient with a high PSA. But kind of remember, if your PSA is going up slowly, it's much better than if the PSA is going up quickly. Okay. And again, the PSA can be explained by large prostate in certain circumstances. So how do we, to answer Mr. Weaver's question, how do we know the size of a patient's prostate? Well, a good doctor can feel the prostate and get an idea. Okay, if it feels like a little kumquat, or it feels like a grapefruit, so that's pretty easy. But oftentimes doctors don't even examine patients anymore. Okay, so they just send them to a urologist or a medical oncologist sometimes, and so then you rely on imaging. Okay, so imaging the prostate, it's very strange. Prostate cancer was one of the very few cancers that you biopsy without knowing where the cancer is. Like imagine my fist is the cancer. Typically they go, oh, your PSA's up, let's biopsy your prostate. They just randomly sample your prostate and hope they caught the cancer. Okay. So that's called random biopsies. It's like imagine telling a lady who has a breast cancer blood test that came back abnormal, oh, your breast cancer marker came back abnormal. Let's randomly poke each breast 12 times or 50 times just to cover your bases and hope we caught cancer. Okay. So 20 years ago, that was the standard, which is very crude and not very accurate, but that's the way they did it. So around 15 to 18 years ago, the imaging modality started improving. So whereas, for lung cancers, we had chest x-rays, CAT scans, colon cancers, we look at the cancer via colonoscopy. Breast cancer, we have mammograms, MRIs. Prostate cancer is blind. Okay. So now, the last 15 to 18 years, the emergence of better imaging has helped us manage a patient. Okay. Number one, helps us manage a patient with an elevated PSA by telling us, hey, if you have a small prostate, then the PSA density is not good, then you might want to investigate further. If you have a large prostate, oh, that could explain the elevation in your PSA. So even imaging alone and telling us the size of the prostate is a Very important, helpful factor. More importantly, imaging sometimes shows up spots. And then if you have a spot, then you could feel more confident, oh, this is where the cancer should be, and let's just go after the spot rather than randomly poke around and hope we get something. Saves the patient a lot of pain and suffering, such as bleeding, infections, pain, and you're going to have a better likelihood of diagnosing what we're dealing with. Okay. So imaging using color Doppler ultrasound and contrast 3 Tesla MRIs has completely revolutionized how we manage prostate cancer from the first step on, the initial PSA elevation. So a little bit more about imaging is, let's say, so the perfect scenario would be a patient with an elevated PSA. He has a giant prostate, and he has no spots. So then, as a clinician, I'd feel a lot more comfortable telling the patient, well, you know, it's a little bit nerve-wracking, but I don't see anything worrisome, and this PSA can be explained. Let's maybe not rush into poking your prostate, because I don't even know where to poke. Okay? It'd be randomly sampling and hoping we caught something. Okay? On the other hand, PSA is elevated, the prostate's tiny, and you see a big tumor taking up the whole half side, well, then it's a no-brainer, right? You know where the cancer is. It explains the PSA elevation. Prostate's small. Hurry up and do a biopsy. And the great thing about it is, let's do an ultrasound-guided, lesion-directed, or MRI-guided lesion-directed biopsy. Instead of taking 12 to 16 blind spots and getting half, meaning if the whole half had cancer, just take 3 or 4 lesions or stabs at the prostate, and you're going to get 100% accuracy or sensitivity in diagnosing prostate cancer. So, quick question. Yes?
Imaging, what about PET CT scanning?
Yes, great question. We'll touch upon that very soon. So the middle ground is, okay, it's not so obvious. It's so obvious there's cancer. It's very obvious it's probably not cancer. Life is never that black and white. That's why we call this 50 shades of gray. Prostate cancer is very variable, okay? So when we have these middle grounds, let's say there's a tiny spot in a big prostate, or a tiny prostate but no spot. What do we do? You know, do we say, oh, let's take a roll the dice and see what happens? And I mean rolling the dice, meaning let's roll the dice and randomly biopsy. That's a little risky. Roll the dice and don't biopsy and potentially miss prostate cancer. So that's the middle ground that we contend with. So sometimes, other than the PSA kinetics, other than MRIs, you know, there's newer testing options. And without going into, we talked actually about these in prior lectures. So there's lots of slides on these topics. So actually, everything I talked about here is in prior lectures. But for predictive testing, before we jump into a biopsy, we could do these. I typically employ these tests. So for people who are obviously one end of the spectrum or the other, I may not need any of these testing. But for patients where there's this gray area, which will help me and the patient decide what to do, we do these tests. So one is a 4K score, which is basically, so PSA is a protein, okay, and it's a type of kallikrein protein. So 4K score takes a look at 4 different kallikreins, total PSA, free PSA, pro PSA, and kallikrein protein. They look at these 4, think of it as a super PSA test. And it's a blood test that you do, it's a one-time procedure. It takes about 3 to 5 days to come back. And the 4K score will give us an idea if the patient has likely a type of cancer that needs to be worried about, so we need to do the biopsy, or the type of cancer that, if it's cancer, it's either not cancer, or if it's cancer, it's probably not clinically significant, not the type we worry about. Okay. So that question, whether it's worrisome or not clinically significant, is answered by actually all three of these tests. The second and third tests are basically urine genetic tests. So they're looking at certain genes excreted in the urine by prostate cancer cells and potentially prostate cancer cells that will also tell us the same, help us guide our decision-making process. So the first test, 4K score, if you talk to your primary care doctor about, is a blood test. The second and third tests are urinary tests. Typically, a urologist might do that before they subject you to a random biopsy. So typically, your PSA is elevated. Your primary care doctor repeats the PSA. It comes back down or stays elevated. Then they have to think, is this a big prostate or not? And that's when they say, okay, well, I'm going to send the patient to the urologist. And then the urologist will look back at all the PSAs, see if there's a worrisome trend or a not so worrisome trend, going up fast or going up slow. And that predicates upon having PSAs over time by your primary care doctor. The urologist or the next doctor would order some imaging, hopefully, and look at the prostate, measuring the size or looking for spots. And hopefully the urologist or clinician will do the predictive testing. And then finally, they decide on doing a biopsy. Okay. So questions on the first journey. Did you have a question there? You raised your hand.
Are these tests covered by insurance and done in the
Yes, they're all covered. Medicare is very generous, and they cover all of it. Most primary insurances will cover one or two of the three, but they won't do all three. Okay.
After radiation, and more so after surgery, if the prostate is showing to be larger, is it more likely that it's the cancer rather than the prostate?
Great question. That's a little bit, can you hold that question until we talk about relapse? And
yes, did you use fiber optics also in a diagnosis at any time?
No. That's an ultrasound. Yeah. That's sonic sound waves. Yep. Okay. Who's next?
When you have one of those random biopsies, which I had, by the way, what are the odds that it misses cancer if it's there and comes back and says, "Oh, you're fine," but you still have it?
Well, it depends on. In general, they miss cancers around 30% of the time. So let's say the PSA is elevated. You come back. Oh, your biopsies were clear. You're not done. What they'll do is let's check another PSA. What if it keeps going up? Guess what? Let's do another biopsy. Randomly poke around. So that's the past, hopefully. So nowadays, most doctors will order a imaging test either before the first biopsy or after, if the first biopsy came back clear.
Also, I've heard a lot about this transperineal biopsy as a less infective
yes.
type. Is that getting any play here?
Not really. With imaging, it at least misses less. So transperineal is a type of approach where the doctor, so typically a biopsy of the prostate goes through the rectum. So the needle actually goes through the rectum into the prostate because the rectum is right on top of the prostate. So I don't know if you guys know, when a doctor examines your prostate, the finger goes into the rectum. So they're feeling your prostate, but it's actually not feeling your prostate. They're feeling the prostate, but there's a wall of rectum separating the finger and the prostate. So when they do a biopsy, they actually go through your rectum, which has poop in it and bacteria, to get the prostate. So that's 12 to 16 pokes through the bacteria poop infested rectum to get samples. So that's where the risk of infections come in. So That's why we want to do less pokes if possible. So another approach, so despite what I just said, the risk of an infection is about 3%, okay, which is 1 out of 30, okay. So another approach is to reach the prostate from the outside, where you can clean it really well and there's no feces. So that's called the perineum. So the area where if you lift up your scrotum, there's a patch of skin right below the scrotum and right above the anus. So that's behind that piece of skin is where the prostate sits. Now we can't feel your prostate from that area. There's too much stuff going, too thick, so we can't feel the prostate. But doctors can do biopsies from that approach, and that approach is it's a little bit more complex. It's like you have to go to an outpatient surgery center. You have to have more anesthesia, but they do. So logistically, it's a little more difficult, and they can safely take more samples randomly, albeit it's not directed at anything, randomly with very little risk of infection, like 1 out of 500. Okay.
More anesthesia is good.
Yeah, like a colonoscopy.
Regular rectal biopsy.
Yes.
Say that's the worst experience of their life.
Yeah, I mean, I've had patients faint in the middle of a biopsy. When you do 3 cores before you know it, it's done. But when you're doing 16, it is torture. It's almost inhumane. Yeah. So imaging is very important in moving us away from random biopsies and allowing us not to need the transperineal biopsies.
So, is there any update on the Trinetra blood test and on the predictive tests? Why would I want the ExoDX versus the Select MDX?
Dealer's choice. So they're different. They're measuring different proteins. There's no study comparing which one's better. Personally, I think maybe ExoDX is slightly more sensitive, but at the same time, it might overcall more. So.
Our speaker last month preferred those first 2 also.
Okay, yeah.
4K and ExoDX.
Okay.
We got 2 votes.
Okay. Oh, perfect. So your speaker touched upon it last time. Perfect.
And what about the Trinetra blood test? Is there any prevailing?
I don't think so. No.
Okay.
Yeah.
Yeah, for the perineal biopsy versus the rectal. So there's a way you could be guided with the rectal, but what about the perineal guiding?
So
guidance?
the perineal is it is random. So they put a template with holes in them, like 50 of them, and then they just go through each hole to take samples. So it's not like, oh, I see a spot there, I'm going to aim for it. Okay. But at least you're asleep and there's no risk of infection.
I thought they did those guided nowadays, no?
Not transperineal. Wow. Yeah, it's still random. Yeah.
I've got a question, if I may.
Yep.
The scans, we've got MRI and we've got ultrasound, which you really are in this talk have been referring to the color Doppler ultrasound, which I understand you have, and what's his name that retired in Ventura still
Dr.
has
Bond,
it. But that's pretty much it in the area, right?
Yeah.
And then the other one is micro ultrasound, though, right? Can you comment on it?
Well, there was a phase where, are you referring to like injecting bubbles and?
No, the high frequency.
Oh.
Higher frequency ultrasound.
That might be for treatment.
No.
Oh, okay. Well, I don't know much about that one. Okay. So I could touch upon the PET scan a little bit. So sometimes when we're not sure, when something doesn't seem right, but nothing is showing a tumor, sometimes we do a PET scan just to see if that area lights up. So PET scan is a nuclear-based test, which we'll talk about further later on, but it's a nuclear-based test where you inject some radioactive dye, and then wherever there's cancer, the dye goes to. And so if we don't see anything, the PSA is high. If we don't see anything on MRI or ultrasound and the PSA is still high and the prostate's tiny, there might be some weird cancer that we don't see. So we'll do a PET scan. If it doesn't light up, then we're very reassured. If it lights up, then we're saying, well, we got to do a biopsy. But we'll talk more on the PET scan later on when we talk about relapse. Okay.
Yeah, for predictive testing, where does genetic testing come, like oncotype? Is that after the biopsy, right?
Yeah.
So you're going to get to that. That's not part of the predictive.
Correct. So predictive testing is, in this situation, does the patient have cancer or not? And if the patient has cancer, is it the serous type or not? Okay, so we have a few more journeys to take, so we're going to go to the next journey. All right, so you're diagnosed, and we are deciding what to do. So refresh my memory. Who is a fairly newly diagnosed person here? Great, so that group right there. So I'll just look over here. No. Okay, so picking a treatment or treatment route, to treat or not to treat is another question. So let's talk a little bit about, let's just go through the standard approaches. So there's lots of slides in previous talks about treatments that I gave, so please refer to that. But typically, we're still looking at cut it out or burn it out. Okay, so cutting it out would be some sort of, we call it prostatectomy, and for many reasons, not necessarily efficacy reasons, the robotic prostatectomy, the Da Vinci machine, is the approach where one removes the prostate kind of laparoscopically, where the surgeon just makes a few holes and uses the belly button and then puts these robotic arms in there, and the arms do all the cutting, soldering, burning. Literally, there is smoke in the abdomen during surgery. If you YouTube the thing, you'll see smoke coming up inside the cavity. So the robot is just arms. You're doing the same gruesome procedure, but it's not a magic procedure. It's still a same gruesome procedure. So that's surgery. And they're trying to perfect some new approaches, but to potentially leave less side effects. But surgery is kind of an option that the urologists, who happen to be surgeons, would recommend. Okay, and another competing approach would be some sort of radiation. So it would be either traditional radiation, intensity modulated radiation therapy. It could be seeds, where they put permanent radioactive seeds into the prostate, and it releases. So the beam radiation is beamed from the outside, external beam radiation. Okay. The second type is you put radiation into the prostate via little pellets called seeds, and they stay in there forever. So you're kind of burning the prostate. Okay. Variations of radiation include SBRT. Okay, we call that stereotactic body radiotherapy. There's some nicer, more glamorous names: CyberKnife, Gamma Knife. So those are, but it's not knives. It's just radiation. You're burning. Okay, so you're burning the whole prostate. And SBRT is so traditional beam radiation is 28 visits, 5.5 weeks to the radiation doctor. Okay. SBRT, it's more precise, so that allows them to dial up the strength of the beam, and then the practical benefit is it allows less visits. So 5 visits, and which is equivalent in success rate and side effects versus the 28 visits. Okay, so that's SBRT.
I think you can hear me. I just want to say to some of the newcomers, I happened to go to this one doctor. I was a Gleason dying, pretty high up there, and this radiation guy in North County, wanted to treat me with radiation. Luckily, I went to him first and his partner, Carol Sale, down in, she's pretty well respected here in the area. She said, he wants to cure you with you're a Gleason 9 with radiation. You have to turn that into a lump of coal. And she talked me out of it. I 100% agree with it once I learned more. If I hadn't talked to her after that, because radiation seemed like an easier way to go, and I think obviously there's the right time to do it. I did and get 39 radiation treatment. But for the newcomers, radiation sounds appealing because there's not the surgery, the smoke, the burning, but really make sure you hear both sides of that. Just thank God I went to her afterwards. I wouldn't be here today.
Yep. So yeah, you definitely, every situation is different. Some patients should go the surgery route. Some patients should do the radiation route. It's a complex decision-making process, and so yes, that's true. Back to the radiation, traditionally it used to be 28 days. Now it's 5 days. Gamma knife is 1 day, 2 visits, sorry, 1 or 2 visits. So every patient would, it's not like a one-size-fits-all. So every patient has the right answer, right treatment for that one patient. Okay. So the newer approaches to the surgery approach versus radiation approach is not only the less visits approach, but now they're also doing temporary seeds where they don't leave the golden pellets in there, or platinum pellets. They remove them, they put them in and they remove it within an hour. So there's no permanent items in the prostate. So that alone is interesting. Oh, I don't have any, metal in my body. That's actually not the selling point of this approach. This approach, for logistic and practical reasons, they're able to do focal therapy now with temporary wires, temporary seeds into the prostate. So instead of, I alluded to earlier, when we do surgery radiation, we're removing the whole prostate, or we're turning the whole prostate into a lump of coal. Okay, but nowadays there's various focal therapies, and my favorite focal therapy now is the focal HDR, which is focal temporary seeds, and that ties into imaging. So if we do a MRI ultrasound and we see that the cancer is on one side and the biopsy shows that it's proven to be one side, why cut the whole prostate out? Why burn the whole prostate? Why not just do kind of a lumpectomy analogy of the breast cancer management? Why don't we just do partial focal treatment of the prostate? You should have less side effects, that's for sure. Okay, and if you could get rid of less of the prostate and still achieve a good cure rate with less side effects. So that's something to consider. Now, the first focal therapies that came about were cryosurgery and HIFU. Okay. Cryo is basically freezing that half of the prostate. HIFU is basically using the sound waves from the ultrasound machine to heat up that half of the prostate. Data just came out this year that the long-term success rate of that approach is only 50%. Okay, so you treat half the prostate, but there's a 50% chance you're not done. So there's no free lunch in life. You can't just treat half the prostate and be guaranteed the same as treat the whole prostate. So of course, if you do focal, you have to find something that's very effective focally, and also you got to monitor the untreated part. Just like when a lady goes through one treatment for the breast, they watch the rest of the breast and the other breasts. They're not done. Just for prostate cancer, if you do focal therapy, you should do, you got to keep monitoring. So in terms of the reason why my favorite focal therapy now is HDR, high dose rate seeds or temporary seeds or wires, is the success rate of getting rid of that focal spot is probably 90%. Okay, it's a very effective treatment. And then of course we still have to watch the other side. So, a good radiation doctor could give a lecture on that, or counsel you on that. And It is kind of a new field, so there's not that many doctors doing it. Albert Chang at UCLA is excellent, and the data that I'm quoting at 90% success rate is Albert. Okay, so he's really good. Yes. So
what is the status of the proton beam?
Thank you for bringing it up. So proton beam falls into the category of external beam radiation. Okay. The status is it's still alive and kicking. They treat the whole prostate. Sometimes when you read their brochures, they say, oh, the radiation goes directly into the prostate and it skips everything around the prostate. Okay. It's not that amazing. It just has less radiation to the area around the prostate, but they treat the whole prostate, not just the cancer. Okay, I would say in terms of the success rate, it's equivalent to beam radiation. Side effects are actually, similar, which are low. That's the great thing about, turning the prostate into a lump of coal. It is low side effects, and one caveat is oftentimes. A standard approach for beam radiation is you inject a kind of a silicone gel called hydrogel. It's also known as space ore. So remember I said the finger exam is on the rectum over the prostate? So the rectum is right on the prostate. So when you beam the prostate, it's hard not to give a little radiation to the rectum. So what they're doing now is they inject this gel that separates the prostate from the rectum. And so when they beam the radiation at the prostate, less exposure happens to the rectum. That's called hydrogel, and a lot of doctors offer that to their patients. Okay.
So yeah, something I'm looking at is space OER or whatever. But anyway, is there reasons to choose it or to not choose it?
Good question. There's no additional side effects, but it hurts a little bit when they're injecting the gel, so maybe 10 seconds of pain. But the reason would be some doctors would say, oh, you're not going to get side effects, don't bother. So in other words, without the gel, the risk of long-term side effects from radiation is about 5%. So 1 out of 20 people will be not happy after radiation. If you do the gel, the risk of long-term side effects is 1 out of 60. So you're treating, if you treat 20 people, you're maybe changing the destiny of that one person who was destined to suffer. So, the side effects are not that bad with radiation, but it could be less likely if you do the gel.
That you're introducing something else into your body that will you notice?
I think no, you won't notice it. The gel is kind of similar to what people do with plastic surgery when they inject fillers and stuff, so to get rid of wrinkles. So it's safe. Yeah. Okay. Yeah, it dissolves. The body reabsorbs it, But yeah, you are introducing something foreign. Yeah. Okay.
The other thing with the gel, should the need come in the future for an actual surgery, from what I was told, is when they radiate, it damages the surrounding tissue, and it's very hard for the tissue to heal or mend back up. So I would think one thing about the gel, if it's protecting, a colon cancer or another thing in the future, or that escape the organ, the prostate cancer, and they may have to go in for some surgery, it would heal much better. Right?
Yeah, that is probably true. Yeah. Okay. One more question before we talk a little bit more about this second journey. Yeah. Okay.
And this is for the benefit of the people newly diagnosed. There's a tendency, I think, when men learn they have prostate cancer to just say, well, if it's prostate cancer, just have the prostate surgically removed. That's the end of it. Can you speak to that?
Yes. So when yeah, we like to fix things, and it seems like the easiest fix is to open it up and remove it, which is seems logical. It turns out that when you remove a prostate, it's a complex procedure. It's not like you just go in and scoop it out and we're done. There's a lot of cutting and sewing and cauterizing and reattaching, and so it's not a walk in the park. There's some complications. There's some recovery time, and this statement about I could, if I do surgery, if it comes back, I'll just radiate it. You actually don't want to do that. You want to do one treatment and be done with it. So if you do surgery, you almost want to, for surgery, you tend to want to treat the low to medium risk patients with surgery. And this is just a general statement, because for high risk patients, you got to be mentally prepared that once you do surgery, you're going to need radiation afterwards. And that's not necessarily a good thing, because you get way more incontinence, way more sexual issues. So, things to think about. Okay. Last question, that gentleman.
Can you discuss perineural invasion and radiation?
Sure. So perineural invasion sounds like a terrifying word. Okay. So basically, the prostate has nerves in it, and the nerves originate from bigger nerves outside of it. So one thing that the pathologists say on a report is, there's some cancer cells on the nerves within the prostate during biopsy or surgery. And so, okay, the cancer cells can hop along the nerves and go outside the prostate and spread. So about 25 years ago, the word perineural invasion implied that there's a higher risk of spread and relapse. So invisible cancer cells left the prostate before it was treated. It turns out that perineural invasion is not that powerful of a predictor of relapse. So it's not as scary anymore. Okay. All right, so for the interest of time, this journey, we still got a little bit more to talk about. So sometimes we include hormone therapy, or what I call anti-testosterone therapy, which we use primarily with the radiation approaches. So because the radiation treatments are typically for medium to more advanced cancers. So just like I said, surgery, you often need radiation help afterwards. Radiation, sometimes you need hormonal help during or afterwards. So there's a lot of algorithms on when to incorporate hormone therapy when we treat the mothership. Okay, so hormone therapy has its own side effects, which Aaron alluded to earlier. So there's a role to decide on whether or not to do hormone therapy. Okay. Yes.
Question. If you're on hormone therapy after you've had radiation, let's say, and it shows...
Let's talk about that's during relapse. What's that? That is during the relapse journey. So when we talk about relapse, please don't forget to ask that question. Okay. So another option in terms of management is maybe no treatment. Okay. So why do no treatment? Because every treatment has risks, and that us doctors tend to minimize, but you guys are the ones going through the after effects. When we're done with you, we're done with you, okay? But you guys will potentially have sexual side effects, urinary side effects, bowel side effects, psychiatric side effects. One patient shot a urologist to death in Newport Beach because his other urologist screwed up, and this innocent urologist got shot 6 years ago. Crazy, right? So one approach for men who get diagnosed, but get diagnosed with the good type of prostate cancer, which there are, those are the types of cancer that will probably never affect one's life. Those are the types of cancers that you tell the patient, you're going to die with prostate cancer and not die from prostate cancer. So those are the good types that may not even need treatment. You've got to consider active surveillance. Active surveillance is there's lots of slides on it in prior talks. Active surveillance is actively monitoring the patient even after diagnosis to learn more about the cancer, betting on the cancer will never cause problems. Okay. But if it ever did, looked a little bit more, if it's changing and changing its colors, don't look as nice as we thought, then you're actively monitoring, then you treat. Then you treat with surgery and radiation or whatever other options. So this is an important factor because 20 years ago, no patient had that option, okay? And it was always cut, cut, cut. Now, and that actually led to a period where the government says, we're over-treating our patients. Let's stop doing PSAs. So from like 2014 to 2018, half of the primary care doctors stopped checking PSAs because they were over-treating patients and not changing the destiny of enough people to justify testing PSA and over-treating. So now that we have active surveillance, we have another option. Okay, fine, let's not put our head in the sand. Let's find out if he has cancer or not. So primary care doctors are testing again. But once we find out if they have cancer or not, do we treat or not? So because we have active surveillance as a very valid, logical option, PSA testing is on the rise again. Okay. Very important study that came out a month ago, 15-year follow-up of, I think, 1,800 men, 600, 600, 600 in the UK. And all these men were the favorable prostate cancers. Should you do surgery, 600 people. Should you do radiation, 600 people. Or should you do active surveillance? Doesn't mean do nothing forever, but watch these patients. Okay. Turns out that the 15-year survival for all three groups was the same. Okay. Wow. So you can't say, oh, we need long-term follow-up before we recommend active surveillance. You're taking your life in your hands. Turns out that survival's the same. And of the group that got active surveillance, half of the people never had treatment. So yes, during surveillance, about half the people over 15 years will eventually get treated and get the side effects, potentially. But half of the people never needed treatment. And I have patients that I've watched since 2001, and they still haven't been treated. Imagine if 2001 they lost their prostate. They would have had 20 years of some, definitely less sexual function, and 20 years of potentially incontinence. Okay? So active surveillance is something to consider. Not telling everyone needs it, but something to consider that they got to talk with their primary doctors about. So basically, those we talked about the factors that guide decision making. We kind of covered a lot of it, but high risk patients, you got to do something. Either surgery, radiation, or a combo of things. Intermediate risk patients, you typically do one type of treatment and you're done, hopefully forever. The low risk patients, you got to consider active surveillance. It's almost, I wouldn't say malpractice, but it's totally uncalled for some people with good risk prostate cancers. Okay. So let's do 3 more questions on this journey. And let's try someone who hasn't asked yet.
When you're in active surveillance and you've had a positive biopsy in the past, how often should you get another biopsy? Or what's the recommendation for that?
So it's evolving. So in the olden days, when active surveillance started 12, 13 years ago, Hopkins was doing a biopsy every year, a random biopsy. So they basically biopsy until you give up and say, treat me. Okay. So now, a lot of it's image directed, guided. So if you keep seeing nothing over the years, why randomly poke? Okay. Maybe do one more in that first 5 years, maybe, or maybe none. So yeah, I wouldn't re-biopsy that often. Okay. So I think this gentleman here.
Is there a way of getting your Gleason score without a biopsy?
No. So the Gleason score is you take samples and you look at under the microscope, and then the microscope cells will tell you what type of Gleason score. Now on that note, the predictive testing for people who, like the 4K score, EXO score, Select MDX, those are tests that tell us the odds of one having good or bad Gleason scores. So if the odds are good, it's not a definitive, it's just a predictor. If the odds are good that one probably doesn't have the higher Gleason scores, we may consider not doing a biopsy right away. Okay.
So thanks you so much for a lot of really great information. One thing, and we're in the guide for decision-making process here, if I were intermediate unfavorable and trying to decide whether to use hormone therapy, my preference would be not, if not necessary, but what would compel me to also include ADT?
Sure. So one thing to consider is hormone therapy is only 4 months now. So it's not as bad as before. And hormone therapy basically, still has some side effects, but one gets over it fairly quickly. In terms of whether or not to do it, it's your, how much insurance you want. So typically, unfavorable intermediate risk prostate cancers, your cure rate is very approximate, about 70%, okay, without hormones. Okay, so you do surgery or radiation, and 7 out of 10 chance you're done. Okay, if you do hormones, it goes up to 80-ish%. So it's insurance. Okay, so in other words, let's say there's 100 of you, and we treated 100 of you. 70 will be done. 30 will not be done. If all 100 of you got hormone therapy in addition to treating the mothership, the 70 who are done anyway, but 10 of the 30 would have been pushed to the done camp, and 20 of you would still not be done. So you're treating 100 of you to change the destiny of 10. Okay, but 1 million people buy earthquake insurance for that reason. You're hoping that only you don't get it, but if you're destined to need earthquake insurance, you have it. Okay, so we got 3 more pathways to go. So let's do the next one. All right. Okay, so this so another journey is you're cured or not cured, but you're dealing with residual side effects or actively managing side effects. So who could tell me in here that they have no side effects from their treatment? Raise your hand. 1. Great, congratulations. Okay. Anybody else? 2. Okay, so that's really good. 2 out of 100? Okay. So in other words, unfortunately, it's hard to come out of this unscathed. And on the other end, I do have to remind people, well, we can't blame all our symptoms on the treatment. Sometimes as we age, we get symptoms anyway, and it's easy to just blame it on what we went through, but sometimes we do get incontinent as we age, okay? We do have, our sexual function goes down no matter what, okay? So maybe it's not due to the treatment, okay? But oftentimes treatment does impair sexual function more, okay? So these are the fun souvenirs we get. Number 1 is erectile dysfunction. So the more you do to the prostate, or the more treatment you get, the more likely you're going to get erectile dysfunction. The older you are, the more likely you're going to get erectile dysfunction. The worse you are before treatment sexually, the more likely you're going to get erectile dysfunction. So it's not like you're impotent and after surgery you become potent. No, it's things don't get better. But so those are the factors that contribute to worsening erectile dysfunction. So in other words, with intermediate risk prostate cancer, you do radiation. You probably don't want to do hormone therapy because it could make erectile dysfunction worse, typically for a while. If you do radiation, you don't want to go back and do surgery because that's 2 different treatments to that area. Okay. Same with surgery. You don't want to say, oh, I'll just do radiation afterwards if it fails. You don't want to do 2 types of treatment to that area. But let's say you did, or let's say you're unlucky and your erections are not as good as before. Okay. So what are standard treatments? One is, of course, the pills, Viagra, Cialis, Levitra, Stendra. Luckily, most of them are generic. So with the GoodRx coupon card, these pills are less than $1 a day, so they're no longer $300 for 10 pills. So the pills work somewhat, okay, but they don't always work. And then that's when you try other things. So urologists will say, well, we have a sound wave machine. I blanked out on what the name of that machine is. And you do the sound waves, ultrasound to that area. It dissolves some of the scar tissue and opens up some blood vessels. So maybe about 1 out of 4 people will benefit from using sound waves, okay, to help with erections. A more effective approach is actually penile injections. So you're actually injecting similar compounds as Viagra, vasodilators, using a very thin syringe, very small amount, like a drop of the medicine. But you do inject it into the penis, kind of like injecting insulin. Okay, and that works 80–90% of the time. Sometimes it works too well. Okay, so and that's where you go to the emergency room if you have an erection that lasts more than 4 hours. So one of those. So it happens maybe 1 out of 20 times with the injections, but that works really well. And of course, if you're really motivated, you do a penile implant, another surgical procedure. Okay, so that's impotence in a nutshell. One thing you got to think about with erectile dysfunction is you could have a good sexual a fun time has a lot of factors. It's not just having a good erection, but you also have to have a good desire, okay, to get emotional, psychological satisfaction. So it's not just the firmness. So with that, sometimes it's related to, the lack of testosterone. And that could be a side effect of androgen deprivation therapy, hormone therapy. It could be a side effect of aging. We make less testosterone as we age. It could even be a side effect of radiation 20 years later, that we make less testosterone. So if you're cured and you're not satisfied with the sexual, emotional, libido aspects of sexual function, testosterone supplementation could be considered. So giving testosterone to make the patient more higher libido, more horny, okay? And that could be something to consider as well. Okay. Briefly, the urinary inflammation is typically related to the seeds or the wires, and that happens in about 1 out of 20 men after that type of radiation treatment, and that's manifested by, especially the first 6 to 24 months, you could have more frequency, more urgency. When you got to go, you got to go. If you're getting up 3 times, typically you might have to get up 5 times, okay? Or when you're peeing, it feels like a little burning. So that's a radiation burn side effect to the urethra, the tube that goes from the bladder out your penis, and also to the bottom of the bladder, okay? So that could happen to a lesser extent with the beam radiation or the proton radiation, but a little bit more likely, 5%, with the seeds wiring process. The treatment for inflammation is waited out. Okay, you could take anti-inflammatories. You could take supplements like vitamin E and C, cuts down on inflammation. Okay, there's a drug called pentoxyphylline that cuts down on inflammation. Okay, for patients who have inflammation to the point where they're bleeding. Okay, so they're peeing blood in their urine. Hydration is the key to dilute the blood. You wait it out. Sometimes the urologist needs to go in and kind of cauterize things. And one of the more promising and successful treatments is hyperbaric oxygen. Okay, so how many people have chronic visible blood in their urine in here. Very personal, but so there's 3. So typically the risk of that from radiation is, seeing a little bit is probably 5%. Seeing lots of blood where you need intervention or where it's kind of serious, about 1%. And you may, so hyperbaric oxygen might be your approach. So that's the urinary inflammation type of side effects.
And sorry, what is hyperbaric oxygen?
So you sit in an oxygen tank for 2 months, 1 hour a day for 2 months. Sorry. And it promotes healing of the friable, messy blood vessels, essentially. And we use it for other conditions as well, but it turned out it works really well for bleeding from radiation damage. Okay. And it works for rectal bleeding if the radiation burned the rectum. Much less needed now because of the hydrogel. Did you have a question? Oh, okay. So a little bit about incontinence. That's actually, when I ask my patients, what is it they fear the most about prostate cancer treatment? It's actually incontinence, because it's messy, it's smelly, it disrupts their life, they can't play golf, they're stuck at home, and it's kind of depressing, when you're changing pads and wetting your pants all the time. So that's the biggest fear, it seems like, and I guess erectile dysfunction would be number 2. So surgery is the most common cause of erectile incontinence, and cryosurgery is the second most common cause, and that's one. Actually, more likely cause of incontinence is cryo over surgery. Therefore, cryo is one thing that people aren't doing as much. Radiation therapy has a very low risk of incontinence, so we're looking at 5 to 10% for surgery, 50% for cryo, okay, and about 1% or less for radiation. Okay. So if we take away cryo, because that's not a common treatment anymore, it's basically surgery 5 to 10% or radiation 1% incontinence. Granted, surgery doesn't cause inflammation, doesn't cause rectum toxicity. So full disclosure, balance everything. But incontinence is very not uncommon for surgery. And the definition of incontinence is very variable too. Needing, 1 pad a day, we're probably looking at over 10%. If you're 80 years old and you had surgery at age 70, there's probably a 20% chance you need a pad. If you're 50 years old, the likelihood of needing a pad is only 1%. Okay. So age is a factor, and who does the surgery is a factor. Dr. Salem is an excellent surgeon. Her risk of incontinence for her patients is very low. Okay. And her risk of incontinence for her young patients is supremely low. Okay. So that is a factor. How do we manage it? Well, the first thing is after surgery, you got to start rehabbing that area by doing the pelvic floor exercises, otherwise known as Kegel exercises. Basically strengthening the muscles down there just to squeeze squeeze down on the floors of your perineum, which cuts off the urine from leaking from your urethra. So Kegel exercises are very important. There's no pills to take that fixes a leaky area, but you could take overactive bladder pills to cut down on the... So when one has incontinence, it's not just there's an opening and the urine is dripping out. You try to close it with the Kegels, by the way. But if the bladder is overactive, it's always kind of squeezing or twitching, you're going to squeeze out more urine and cause incontinence. So it's not only treating the urethra, the pelvic floor muscles, but you also got to treat the bladder to make it not want to squeeze out the urine. So that's another treatment for incontinence. If it's still terrible, then doctors at USC especially are very good at doing artificial sphincters. So basically it's a cuff that they surgically put in there, and it's an inflatable You know those inflatable lifesavers that kids wear on their arms when they're floating in the pool? So it's basically a cuff surrounding the urethra. So you press a button and the cuff inflates with water, and it cuts off the urethra. So that's what we call, and it's actually always inflated, so the urethra is always closed. So with this artificial sphincter, you press a button and the cuff deflates with liquid, and then the urine comes out. So that's how you control your urine. When you go pee, you walk to the toilet and you press a button and the button comes out. The urine comes out. Like a soda machine. So no one's going to want to drink soda anymore. So that's incontinence. It works, okay, and it's 90% happy patients. The downside of that is in about 10 years, they got to change it. So it's kind of like a pacemaker, doesn't work forever. These artificial sphincters don't work forever. Okay, so quickly, rectal toxicity. It's rectal burning from beam radiation, not seeds, not surgery, just beam radiation, occasionally proton. And that's manifested as mucus discharge, blood in the stool, more frequent bowel movements. So like if you typically go once in the morning, you might need to go 3 times in the morning. Or when you got to go in the afternoon, you better go or else a little mucus comes out. Okay, so that's rectal toxicity. And that's from the beam radiation damage of that area. Okay, now with the gel, the risk of that is less than 2%. So much safer. And you know, they're getting better at pinpointing the radiation. So the risk of rectal toxicity is low, but if it happens, Kegel exercises help because you're also strengthening the muscles down there. Occasionally, you could cauterize a bleeding vessel. And the third treatment is time. It gradually gets better. And once in a while, if necessary, you do hyperbaric oxygen, okay? And it heals the bleeding. Okay. Last set of side effects is the hormonal side effects related to anti-testosterone therapy. Again, we use it for the medium to high-risk patients to improve their cure rates. Side effects of androgen deprivation therapy or hormone blockade or anti-testosterone therapy is hot flashes, depression, bone loss, muscle atrophy, weight gain, decreased libido, thin skin. So a lot of the stuff that we associate with when a lady changes in her transition, life transition from menopause. So the risk factors for all these side effects is age, the length of treatment for androgen deprivation therapy, not taking breaks, yeah, those are major risk factors. So one key is, luckily, we're able to do shorter courses of androgen deprivation therapy. We're also, so for example, in the unfavorable intermediate risk patients, instead of 6 months, 6 to 8 months, we're doing 4 months. For the high risk patients, it used to be 36 months of castration, okay, in addition to the radiation. So now the movement is, now the standard is 18 months, which is still not wonderful, but it's 18 months. And just this year, there's some new data showing that for certain patients, high-risk patients, that we were going to propose 18 months, you could get away with 6 months. Okay. So potentially the risk, the necessity of needing hormone therapy, although still there, but it should be less patients needed and a shorter duration. Maybe at most 6 months.
How long after you discontinue the Lupron, after you have that last shot, how long does it stay in your body?
Well, the chemical stays not too long, like a month, okay? But the effects could last for a long time. So, and why is it that what these chemicals are doing, they're actually hormonally directing your testicles to stop making testosterone. So when the medicine is out of the body, the testicles may not, it's not like they wake up the next day and start making testosterone. They take time to wake up, okay? So it could take a month, it could take 6 months. If you're on it for 4 months, your testicles will wake up in 1 to 2 months. If you're on it for 18 months, your testicles could take 6 to 12 months to wake up. So even though you're done with the treatment, you still have some side effects. So, and sometimes on that note, we actually even consider giving people testosterone if their testicles never wake up, because our intention was for them to make testosterone, but their testicles didn't wake up. Okay. And why does that happen? Well, the older you are, if you're not making much testosterone anyway as you age, when you get rid of whatever you're making, you're not going to make more than before. Okay. So we might even give people testosterone. So the factors that determine how long it takes to recover from your last Lupron is your age, how long you're on Lupron, and what you were making before you got treatment.
How likely is it for, or what percentage of patients completely are cured, quote, cured from side effects from TIP once it's stopped? If you take it for 4 months, 6 months, I mean, breast enlargement, weakness, fatigue, emotional lability, all of that, does that all go away for most people?
Yeah, I would say if at 4 to 6 months, most people will completely normalize. Yeah. It could take 1 to 6 months, though. Yeah. And one way to minimize the treatment side effects of androgen deprivation during treatment is diet and exercise. So very important. How you tolerate this treatment is very correlated to how much weightlifting you do. So every patient I have on androgen deprivation, I would suggest they do weightlifting, either hire a trainer, do it on their own, or I give them a prescription for physical therapy.
There's a program at the YMCA that's specifically directed towards that, and I have a friend that went through it. He was a real serious patient that had to do AET for a long time. He said it really saved him.
It's a life
And it's not only the exercise, which is helpful, like you say, but it's he was going through it with his other buddies. And if his other buddies didn't show up, they would find out what's going on with him.
Yeah.
So there's really the community that really helps. So the YMCA of La Jolla.
Well, that's a great resource. Yeah.
Well, the fact that we know or should know that testosterone is the evil factor that feeds the cancer, at what point do you prescribe testosterone and for how long, and what are the risks?
So I mean, it's obviously, if I'm 100% sure a patient is cured, meaning he has no cancer in his body, I could give him all the testosterone he wants, and he'll be fine. Okay. So if I'm sure he's cured, yes, do it. If I'm not sure he's cured, but his life is terrible, well, that's when we have a long talk. And remember, if we gave that patient anti-testosterone treatment, androgen deprivation therapy, and we stopped it, our intent was for him to make his own testosterone. So we were not afraid of testosterone because, we're telling the patient, we're not afraid of testosterone, we're stopping the treatment. If we're so afraid, we could castrate everybody with prostate cancer and never let them have testosterone. So it's always a balance between risk and benefits. So yes, so we give patients testosterone even if there is a risk of the cancer coming back. And because if we don't want any risk, we would castrate them forever. Okay? So that's something to consider.
I took 1 shot of Lupron and went on Zytiga. My testosterone is being maintained at a very low level without Lupron at this time. If I were to stop Zytiga, for example, today, would the testosterone recover faster than if I were taking Lupron?
So you're off Lupron?
I've taken it once, like 9 months ago.
Okay. Yeah, you'll probably come back faster. Yeah, yeah. Okay, so we actually have it's already 11:30. Wow. Okay, so we have two more pathways in the next 20 minutes. Okay. So dealing with relapse. Okay, so who has relapse in here? Okay. So actually this talk is like, the relapse part could be a whole hour. I'll try to be efficient. So the most common scenario when one relapses is, okay, you did your surgery, you did your radiation. Actually, may I sit? Is it okay if I sit? I have a stiff back. Huh?
Not enough exercise?
Yes. No, just, I don't want to say it, but I'm getting old too. All right, so oftentimes the scenario is you get cured, or you thought you're cured, and you're being monitored because there's a chance you're not cured. So you get your PSAs monitored every 3, 6, 12 months, and suddenly the PSA goes up. Okay. Oh. The PSA goes up. And so that means the PSA is basically a protein made by cancer cells. Okay. So when there is a rising PSA, it's telling us that there is some cancer somewhere. It doesn't tell us where the cancer is. It just tells us that there is some cancer. So the first question is, where is it? So there's actually 3 scenarios where the cancer could be. Okay. One is it's still in the same area where it was removed or burned. Okay. So that's what we call local relapse. The second scenario is it's no longer there because the mothership has been successfully destroyed, but there's some cancer somewhere else. And that happened because before the treatment of the mothership, some of the cancer cells had already left the mothership, but those are invisible, okay? So you can't just remove invisible cells, you just remove the mothership and hope for the best. So the second scenario is there's no cancer there, but something's out here, okay? So I jokingly say PSA in the prostate cancer in the bones makes PSA. Prostate cancer in the lymph nodes makes PSA. Prostate cancer in the earlobe makes PSA. It just makes PSA wherever it is. So guess what the third scenario is? It's in the prostate and outside. So those are your 3 scenarios, and that determines how we manage the patient. So if you look at those 3 scenarios, the scenario where you could go for cure again is if the cancer is still in the prostate. So if we're confident that the cancer, so even if the cancer is in the prostate, but unfortunately it's somewhere else, then treating the prostate again is not going to be ultimately successful. Does that make sense? Okay. So when someone relapses, we have to separate, do we think the patient's cancer is only in the prostate or in scenario 2 or 3? Okay. So the way we kind of figure it out is, number one, the higher the PSA, the more likely it's already outside the prostate area. So kind of the cutoff point is 1.0 or below for surgical patients, and 4.0 below for radiation patients. Okay. So let's assume the cancer's still in the prostate area. Well, how do we confirm it? We do MRIs, we do ultrasounds, sometimes even a digital rectal exam. I feel a tumor. It's there. Okay. But nowadays we have the PSMA PET scan, which is way more sensitive than what we had before. So going back in time, before we used to do nuclear bone scans, CAT scans, and they're really very, they don't see anything. So if we don't see anything and we just say, oh, it must be in the prostate, let's radiate it, it's really not because we don't see it, it's not there. It's just the scans were so bad at finding cancer outside. So, and then we had the Axeman PET scan, which is a little bit better. Dr. Almeida had a carbon-11 PET scan. Mayo Clinic had a carbon-11 PET scan. So nowadays we have this PSMA, it's a type of isotope, that's injected into the body, and then wherever the cancer is, it will light up an hour later. Okay, so it's PSMA PET scan. So it turns out that this PET scan will help detect cancer in the prostate and cancer outside the prostate with pretty good accuracy. Yes, so that's Pylarify is a PSMA PET scan. Okay, so it's so good that at a PSA of 1.0, the PSMA PET scan could detect cancer in the bones. At a PSA of 0.3, there's a 50% chance that it could detect it in the lymph nodes. So if you do your PSA PET scan and you say, oh, let's say the doctor says, oh, there's more cancer in the body somewhere, let's radiate the prostate bed. The PSMA PET scan is going to tell us, yes, it's lighting up in the prostate bed, let's radiate it. But more importantly, if it lights up a little bit further away, you could radiate that area as well and still go for cure. Okay, so it tells you more information. So the take-home message to answer this where's the cancer question is the PET scan. Okay, and when do you start doing it? At a PSA of 0.20 and above, you could start talking about it with your doctor.
Back to my original question. If you're watching your PSA month after month after month, it's zero, but you're on ADT, can the ADT mask the effect and there might still be cancer kicking around in there?
Yes.
So how do you know if that's the case? Your PSA is leaving you.
So you're on ADT, presumably knowing that there's cancer in the body. Otherwise, we don't give ADT typically. And then the only way to know is to, when you stop ADT, and then you cross your fingers that the PSA never comes up. And then if you're cured, then the PSA never came up. If the PSA started going up, then we're back to the, uh-oh, you relapsed. Where's the cancer? Then we do the PET scan.
Why, if you come off the ADT, why not do a PSMA PET scan then?
You do, if your PSA rises.
But I'm just saying, since there might still be cancer in your body coming off the ADT, why not just immediately do a PSMA PET scan?
It's just when the PSA is that low, typically it means there's very little cancer, and typically the PET scan will look clear. So it's a very low yield test when the PSA is zero.
One reason is your copay, it's like a $20-some thousand.
Yeah.
It costs me $3,500 each time I have it. And
wow.
And Aetna wouldn't authorize it until I was 1.0. And I'm now at 2.64. They haven't seen anything. I've had 3 tests, PSMA.
So yeah, I mean, it is new, and Medicare is very good about it, but it is a $6,000 test. So, but I think the cost is $6,000. So, yeah. And yes, insurance companies are terrible, but there's a lot of greedy places out there. Somebody needs to keep the greed in place, unfortunately. Yeah.
Let me see. There's so many things that you've been talking about that you make very good sense. I'm really impressed. I know I've seen you a couple of times here, but you really make good sense. And the thing I wanted to address is this. I went through having an intermediate risk cancer diagnosed. I spent 3 years basically doing surveillance, and I kept a very close eye on it. And then I came over actually to Scripps, and I was able to get the PSMA test. In fact, my oncologist gave it to me twice, and it showed absolutely no spread, that it's totally contained in the prostate. Now, the study you mentioned is something that I just saw a while ago. It was in the New England Journal of Medicine. It seems to suggest that as long as your cancer is localized,
the option of treatment or not is, like what you said before, virtually even. That is to say, why get treatment is the question. As long as you're localized, and the PSMA test, I think, is a pretty accurate measurement of that, right? I did decide to get my PSA was going up very fast at one point, and I did decide to get the hormonal treatment. But I agreed with my doctor to do it as long as it seemed to be necessary. It turned out to be about 4 months, and my PSA was down to 1 from 90. Now, to make life really interesting, I got a letter from Scripps explaining that PSA tests during a certain period, about 6-month period, weren't reliable. They had problems with the test itself, yes. So I'm basically trying to figure out now. I've done the hormonal treatment, and I'm at exactly the point you said. I had all those side effects. If I can just get my testosterone back, I will no longer do any treatments.
Yeah, I mean, it's a lot of take-home, a lot of learning points on that one. Quality of life is such a factor, especially, we always want cure to get rid of it. Sometimes the cost is way worse than the benefit, especially the good types of cancers that never need treatment. I mean, it's a balance all the time. Yeah. But my impression is the PSA levels that were mistakenly done at Scripps are not too far off when it was repeated. So that's reassuring. Right?
The 2 most recent tests after the period that they...
Okay. All right. So let's see. So yeah, I mean, in terms of when we relapse, how to treat, it's really, your treatment is really dependent on where it is, if you're symptomatic or not, and other factors such as how old are you, or how's your quality of life? Are you sick with other things? Let's say someone, has dementia and, had colon cancer. They lost their colon already, and they don't recognize their spouse, and their PSA is 1.0, and there's a little bit of brightness in the prostate area, or there's nothing. We don't see anything. Are we going to treat? That seems to be a little overkill. So you got to kind of thread the needle there in terms of treatment. If, of course, you're in pain, any minute the cancer is going to collapse your spinal cord and make you paralyzed, your PSA is 100, you're 45 years old, you got a lot of life to live, and you're suffering, of course, that's an easy answer too. You treat, okay? So there's so many factors that have to do with, number one, what do you treat? Just the prostate or the lymph nodes? Do you do hormone therapy? Do you do radiation to a spot? Do you do chemo? Do you watch? And even within hormone therapy, there's a ton of different options. So there really is, we really have to individualize a management of a patient. Yes.
I asked a question earlier about, and you said hold it for relapse, about the size of the prostate versus the size of the cancer. And back to symptoms, the fact that we know major symptoms of BPH is frequent urination at night. Well, the situation being that after you have surgery or radiation and you're okay for a while, and then later on you're finding an increased urination at night, is that telling you that the prostate is getting larger?
Possibly. So there's a lot of factors that make people urinate at night. But once the prostate's been radiated, it doesn't tend to grow much anymore. But the reason why people urinate more at night after radiation is usually the inflammation from the radiation of the bladder, not because the prostate's growing. Yeah, the inflammation can happen later. And then the third possibility is you can have another condition not related to radiation, such as overactive bladder. Okay, so it's a condition that men and women have that causes urination at night. Other weird things: Parkinson's causes urination at night. Sleep apnea causes urination at night. Insomnia causes urination at night. So, you know, if we pee at night, it doesn't mean it's cancer-related or treatment-related all the time.
Hi, a quick question. Am I correct in assuming that if you have prostate cancer in your bones, are you on Lupron ADT for the duration?
Good question. The traditional answer is you're on it indefinitely. There are exceptions.
My research on the PSMA, it said that the prostate always lights up. Yeah, because.
So it doesn't.
Okay.
If you do, if you're newly diagnosed and you have prostate cancer in your prostate, it may not light up. It could light up. Okay. The more cancer you have within your prostate, the more likely it will light up. Guess what? It turns out that if you have a giant prostate, you could get a low-level false positive. Maybe that might be the. So then it could light up a little bit, just if you had a big prostate, and that's where a good, experienced radiologist is important, because the inexperienced ones will say, "Oh, it's lighting up. The whole prostate has cancer." But we've learned nowadays that simply having a big prostate accumulates a little extra. And then a good doctor would say, oh, you know, this is consistent with having a big prostate. So, all right, so it's pretty good. The last section, last section is managing advanced disease. That I can make a whole talk out of it. So let's do that next time. So we have maybe about 5 more minutes for questions.
A couple of real quick questions. Number one, about trying to decide whether you operate or remove or treatment. Is there with YouTube, is there something that you could possibly see what the operation would look like that might help you determine?
So that's really good. There used to be a lot of urologists, Pittsburgh, and a ton of them. There's active real-time operations on YouTube, and you can watch a 2-hour video of a doctor doing a robotic prostatectomy. It's like it seems like it's all erased. It's so hard to find them now. So, but they're still there. You just have to dig a little bit. I think you can't. You have to sign up in YouTube. You can't just be a guest.
And the other question, real quick, was, well, as we saw earlier, how many people were referred by a doctor? And you, as in the medical profession, why do you think there weren't more people referred to this session by medical doctors or urologists?
I think that this is a really good group, that it's not really replicated in that many places. And I think this is a great group for education, but there aren't that many other ones. So, you know, it'd be nice to keep getting the word out to the doctors down here. And I think doctors don't even have much time to, talk with the patient, and they should utilize groups like this. You know, it really makes a big difference.
Can I help answer that? Bill Lewis, our new president, is spending a lot of time helping spread the word about what we do, and we're getting a lot more interest through YouTube and many other ways to get the word out on what to do if you got it.
May I say something?
You may.
Thank you. So, I think Bill, I'm sure, knows that doctors have very fragile egos. So if you have to go about it as a your work collaboration. We're here to help patients, help patients, to answer a lot of questions that you don't have. We're not undermining you doctors, and we're not speaking against you doctors. We're not anti-doctors here. We're here just to help make your lives easier, because there's a lot of questions to manage for prostate cancer patients, and even from the significant others. Yeah.
Do you see a lot of patients that suffer a side effect of mental issues? Their short-term memory is affected by abiraterone over a long period of time?
I think having lack of testosterone for a long time, be it from Lupron, abiraterone, Orgovyx, castration, I think you're just less sharp. It speeds up the aging process. It's not associated with dementia, so rest assured. Okay. And there's a lady that raised her hand. Yes.
Advanced disease. But is there any science that's showing, because 80% or 8% of those, your statistics show that you all will die within 5 years within advance. Is there any science that's going and being studied that's going to change that?
So a lot of that terrible prognosis that is it's not right. I think that they're basing it on older data. Okay, and advanced disease comes in all shapes and sizes. If you have 1 or 2 metastatic spots, that's still advanced disease, and people live for 15, 20 years with that. Okay, yes, if you have 50, you light up like a Christmas tree. It is pretty tough, but even those patients, the new medicines are helping a lot.
Any information on advanced research? I hear about researchers working on proteins and bacteria that search out prostate cancer and kill it. Will we see that at any time soon?
Not that I'm aware of. I mean, I was just at a recent meeting, and there are no new abstracts on that. Maybe on other cancers. So what is good is, once the other cancers, which unfortunately I'm not as on top of it, but when they find stuff for the other cancers, it will kind of trickle into the prostate cancer research too. Yeah, such as immunotherapy. Yep.
I thought I heard in the PSMA the way that radioactive dye likes the prostate cancer cells, that they're working on some research to attach something.
Yes. So that is lutetium, Pluvicto, which is FDA approved, and there's a couple guys in here who've gotten it, and it works really well. Yep. Okay.
All right. Sorry, I gotta go. I gotta check out. Thank you so much again to Dr. Lim.